In this last video for Lecture 4, we're going to look at confounding variables again. We discussed them briefly in Lecture 2, but now we're going to look at how to identify them when a study has already been conducted and how to account for them in the results. To reiterate what we said in Lecture 2, the definition of confounding is the mixing of effects between the exposure of the intervention, the outcome, and a third variable, which is termed the confounder. Like bias, confounding distorts the relationship between the exposure and the outcome. Confounding can result from either bias or random error. A thorough analysis of baseline characteristics between groups is essential to determine if they differ in known ways. Characteristics that differ and may affect study results are known as potentially confounding variables. For example, if you have selection bias in a cohort study and the groups are unevenly matched with regard to an important variable, this may produce confounding, so we'll always look at the baseline characteristics between groups. Confounding is often known as the third variable problem. Let's remember this slide from Lecture 2 that confounding variables are variables that are associated with both the outcome and the exposure. And without identifying the confounding variable, it can appear that there is an apparent association between the outcome and the exposure. Remember in Lecture 2 we talked about how ice cream sales and murder are positively correlated, but that doesn't necessarily mean that ice cream is causing more murder. The confounding variable there was heat. So heat is truly associated with ice cream purchases, and heat is truly associated with increased murder. If you don't assess for that third confounding variable, heat, you may make an apparent association which is actually untrue. The other example we looked at was coffee drinking and lung cancer diagnosis. A study that found coffee drinking was associated with lung cancer. However, it turned out that coffee drinkers smoke more cigarettes and that obviously cigarettes have been linked to lung cancer, so cigarettes were the third variable or the confounding variable in that study. We know that confounding variables are third variables associated with both the outcome and exposures in our research, but how do we find them? In comparative research where you have at least two groups, we must always look at the baseline variables between the two groups, and we need to look at variables that could be associated with the outcome and could cause us to mistakenly jump to a conclusion which doesn't really exist. We also need to look at variables that are significantly different between the groups. So if a variable could be associated with the outcome, but there's even numbers in both groups and they're well matched, then that probably won't affect the results because it's evenly matched in both groups. But if variables are both potentially confounding and significantly different, then we need to look at them in more detail. Let's pretend that for Dr. Oz's study, the following baseline characteristics were assessed: age, blood pressure, gender, and previous stroke. Patients who took Oz nuggets were much younger. We can see that from our significance test p-value, which is less than 0.05. That means that there's a statistically significant difference between those two groups. Baseline blood pressure is also much lower in the Oz nuggets group. That could be associated with the outcome of heart attack. Once you identify potentially confounding variables in your study based on baseline characteristic assessment, you must address them statistically, or else the association that you observe between your exposure and your outcome will not be the true association. There are two primary ways to adjust for potential confounding variables. One is stratification, which involves assessment of study outcomes based on the presence or absence of the confounding variable. For example, if we think that gender was different between the two groups, so it could be a potential confounder, then we could look at heart attack incidence in men with and without treatment and in women with and without treatment. So we take that variable and split it and then look at the study within those two smaller groups. The second way we can adjust for confounding is through a method called multivariable regression. This is a statistical method which essentially is able to do what stratification does, but it's able to adjust for more than one potentially confounding variable at a time. For now, all you need to know about regression is that it exists to address confounding in multiple variables. You do not need to know anything else about it until the latter half of the semester. Let's take a look at how to adjust for confounding variables using stratification. In this setting, you demand a follow-up study from Dr. Oz using a more public methodology. You say, do the study again in a larger cohort and show me your methods. So he performs a randomized controlled trial. He again finds that Oz nuggets in 200,000 patients are associated with decreased heart attacks compared to placebo, but you again suspect that age may be a confounding variable. You don't think he matched the treatment groups appropriately. Here are the preliminary results in a 2x2 table. The Oz nuggets group had 1,900 heart attacks per 100,000 patients, and the placebo group had 7,750 heart attacks per 100,000 patients. So the relative risk calculation, which you see on the right-hand side, would be the incidence of heart attacks in Oz nugget group divided by the incidence of heart attacks in the placebo group to give you a relative risk of 0.25. We can interpret this that there's a 75% reduced risk of heart attack incidence in the Oz nuggets group compared to placebo. Those were the primary results, but because we're suspicious that age is a confounding variable, since the groups were statistically different with regard to mean age in the study, we can stratify based on this variable. We can look at elderly patients and non-elderly patients separately and look at the results of only those two groups. On the left-hand side of the screen are patients who are older than 65. And as we can see, there were 75,000 patients who were elderly in the placebo group and only 10,000 in the Oz nugget group. So it's clearly very different. But if we look at the results only in this cohort, we see that the relative risk is very different. It's 1,000 divided by 10,000 for the incidence in the Oz nugget group, and 7,500 divided by 75,000 in the placebo group, making the actual relative risk in older patients 1. So no difference between groups. Then we look at patients who are less than 65, which is much more common in the Oz nuggets group at 90,000 and only about 25,000 in the placebo group. Again, when we do the incidence, 900 divided by 90,000 over incidence of placebo, 250 divided by 25,000. Again, the relative risk is 1 or no difference. So although the results seem to be very different when looked at in total, it's because there was a confounding variable of age, and if we hadn't adjusted for it with stratification, that would have led us to a false conclusion. There are a number of ways to deal with potential confounding variables. Some of them involve the ways that you design the study, and then some of them involve adjusting for them in your study. One way to design your study to exclude confounders would be to define your inclusion and exclusion criteria carefully to help assure that the exposure and control groups are very similar with regards to their baseline characteristics. But you also want to make sure that you exclude patients who have obvious confounder variables. So if you're looking at aspirin versus placebo in terms of bleeding, you might want to exclude patients who also take Motrin because Motrin by itself can cause bleeding. So you could exclude those patients to limit the number of confounding variables in your study. You can also use group matching. In this example, say you want to say, I want such and such percent of patients in this group to have ibuprofen in addition to aspirin, so then I will try to get the same percent of patients in my placebo group that's on Motrin and aspirin. Or you can use randomization. If you randomize patients and you have a very large number of patients, you essentially ensure that the control and exposure groups are similar for both known variables that you're actually randomizing based on and unknown variables, because you have so many patients that are so diverse that the variables eventually balance out. The two methods, stratification or multivariate regression, that we talked about can be used if you identify potentially confounding variables in your own study. You must adjust for them because your conclusions will be different if you don't. So let's talk about what you need to take away from this lecture in order to study for the upcoming quiz. Now, I understand that this lecture contained material that is maybe more abstract and challenging compared to previous lectures. But these are the things that you should definitely be able to do for the upcoming quiz. 1, you should know what internal validity is and the 3 main explanations that we've discussed that cause your internal validity to decrease, which is bias, confounding, and random error. For biases, know what the major types of biases are, so no selection bias versus information bias. Know the phases of research when they occur. And then if I give you a scenario to be able to tell me what type of bias is occurring. For random error, I want you to be able to interpret whether results are statistically significant or not. So looking at p-values or confidence intervals, can you tell what is statistically significant? And then for confounding, I want you to know how to identify potential confounders with baseline characteristics and know the methods for adjusting for those confounded variables.